Good evening to all of you. My topic for today's presentation is renal diet for prevention and management of diabetic kidney disease. As Madam has very beautifully outlined the diets associated with decreasing obesity and insulin sensitivity on this. My approach and my presentation will be regarding the management and of diabetic kidney disease and diet in use of it. Sir, can we start the slide, sir?
He's already there. Slide is there, Supratik. Yeah, your introduction slide has come, outline.
Yes,
you can't
sir.
see? Can you not see?
No, I can see, sir. No problem, sir.
Then please continue.
Sir, my outline for today's presentation will be, sir, the clinical practical guidelines on the nutritional management of diabetic kidney disease and the various panel recommendation like the National Kidney Foundation panel recommendation and the ADA recommendation or the KDIGO recommendation, and what are the current nutritional guidelines, what is the sources of dietary protein intake. As we all know that protein intake is associated with decrease in the progression of chronic kidney disease, and comparison of any such prescribed diets with implementation of the nutritional management. So we all know that the prevalence of diabetes has been increasing worldwide. Can we go to the next slide? And the provision of a balanced nutritional therapy in conjugation with pharmacological intervention that optimizes glycemic status and the lipid levels and blood pressure are essential components in treating people with diabetic kidney disease. In our clinical practice, what happens is that we are pharmacological first. We go for drugs first. But there is an approach in chronic kidney disease and rather also in diabetic kidney disease that there should be an approach called food first. We should first put emphasis on the diet, what diet the patient is taking, what diet may help in preserving the renal function for a longer period of time. So in busy clinical practices, we go to pharmacology therapy first, but food first approach is also advisable. Next slide, sir. The clinical practical guidelines on nutritional management of diabetic kidney disease, we know that this is decreased protein intake of 0.8 gram per day, increase of polyunsaturated fatty acids, and decrease of saturated fatty acid and trans fat. Energy intake with normal patients 30 to 35 kilocalorie per day, and sodium less than 1.5 to 2.3, and with more of starch and whole grains and fibers in our diet rather than the sugar, that is the monosaccharides or the disaccharides. Next, sir. In 2007, the National Kidney Foundation, the Kidney Disease Outcome Qualitative Index, published the initial version of its clinical practice guidelines. And in this guideline, the approach was that the kidney patient with stage 5 chronic kidney disease, there is a similar therapeutic approach was also suggested for diabetic kidney disease, rather not very different. And KDO expert panel advised a lenient guideline saying that it should be kept at 0.8 gram per kg body weight, while being avoided at levels above 1.3 gram kg body weight per day. We know that even a diabetic, which is non-proteinuric, non-hypertensive, a heavy protein diet will put pressure on the kidney by hyperfiltration. And so a heavy protein diet, as is accustomed to Western countries, 1.5 or 2, almost 1.61 gram per kg body weight, even in a diabetic patient who is not having kidney disease, is not recommended or not healthy. Next slide, sir. So what are the practice guidelines for the nutritional management of diabetic kidney disease? A long-term decrease in dietary protein intake below 0.8 gram per kg body weight per day is beneficial, certainly beneficial, although it is not universally accepted, might be beneficial for diabetic kidney disease, although it is acknowledged in the KDIGO guidelines that there wasn't enough proof to back up such an assertion. So experts suggest this is a ADA guideline, modest protein intake of 0.6 to 0.8 gram per kg body weight, containing 25 to 50% of high value biological value protein. But even now, this KDIGO is silent on what exactly is the high biologic value protein. They have written it is a high biologic value protein, but they have refrained from identifying such high biological value protein. Next slide, sir. This I have summarized all the guidelines of the various societies, the NKF, the KDIGO, the ADA. And what I have summarized from this is that the protein intake should be less than 15% of the total calories, or the required dietary estimate of 0.8 gram per kg body weight per day for patients with diabetic kidney disease. And emphasis is put on vegan protein source and non-fat or low-fat dairy protons are recommended. We know that the CKD or the diabetic kidney disease is much of acidic environment. So vegan proteins, unlike the animal proteins, are and the substitute is base, but more of animal protein will lead to an acidic environment. But these patients for CKD 1 to 5 or diabetic kidney disease, once they go to dialysis, and due to more protein catabolism, due to loss in hemodialysis or loss in CAPD, this has to be modified to a level of 1.2 gram per kg body weight protein in ESRD treating with dialysis. For carbohydrate, there is no specific recommendation, but there should not be more than 10% calorie intake as simple sugars, which is the table sugars, is the glucose, galactose, all thing. And we have to monitor the potassium and the phosphate level. As we all know, in advanced stage of chronic kidney disease, the risk of hyperkalemia, hyperphosphatemia, and hyperparathyroidism, increase FGF23. Fat also, specific recommendations are not available from any of the guidelines, but some guidelines have suggested in the last 2020 guideline from the NKF published in EDUCAD, recommended use of omega-3 and omega-9 polyunsaturated fatty acids in CKD 1 to 4, but not in dialysis patients. So, and sodium, we all know that it has to be restricted to less than 1.5 to 2.3 gram per per day. That is roughly equivalent to 5 gram of sodium chloride. And use of non-processed fresh food and utilize sodium-free herbs and spice. Sodium restriction should also be individualized. Next slide, sir. Sir, next slide, sir. Although dietary therapy is a crucial component of diabetic kidney treatment, but due to the ongoing debate and knowledge gaps regarding specific therapies in this population, clinical practice guidelines do not entirely address all nutritional management issues. We cannot hard and fast say that this diet, that this approach is perfectly fit for diabetic kidney disease patients, or rather also for chronic kidney disease patient of any etiology. Additional, due to change risk to benefit ratio profile of a particular management regime across various levels of renal function, recommendations alter across these phases of diabetic kidney disease. A patient of diabetic kidney disease, say of GFR less than 60, will not have the same diet as say GFR more than 60. Or a patient of diabetic kidneys on hemodialysis will have an entirely different diet than that of a non-dialysis patient. So it has not been tailored to one single entity. Next slide, sir. Continuing that, for instance, intense glycemic control has been linked to higher risk of negative outcome in advanced chronic kidney disease and ESRD, with patients becoming more prone to hypoglycemia. And for diabetic kidney patients with stage 5 chronic kidney disease, a similar therapy is also suggested. KDIGO expert panel proposed a lenient guideline saying that dietary protein consumption should be kept at 0.8 while avoided at a level of more than 1.3 as earlier told. So next slide, sir. The guidelines also suggest that there is inadequate proof that these patients would benefit from a long-term reduction of dietary protein intake of below 0.8 gram per kg body weight per day. So as a more successful dietary approach, some experts advise a low protein diet of 0.6 to 8, or even a very low protein diet. We know that still there, which is complemented with keto analogs. So what is the ADA, the ASN and the NKF consensus? This is a consensus meeting in 2014. But last, the ADA expert panel suggested a normal amount of dietary protein intake of 16 to 18% of total calorie intake for diabetic kidney disease patient when it comes to dietary protein consumption. But the KDIGO and the ASN and the NKF, they have suggested a protein intake of 0.8 gram per kg body weight. So accordingly, we are different in our approach under different guidelines. This is the next slide, sir. Next slide, sir. What are the existing evidence and gaps in knowledge in the dietary management of diabetic kidney disease? Which meta-analysis have associated with low protein diet with preservation of GFR we have seen in type 1 diabetes. But what is the ideal amount of protein intake has not been clarified. What is the source of protein? High value, biological value protein, it has been written, but it has not been actually found out that which dietary source of protein is the best. We have know that protein originating from vegetable source is associated with less risk of proteinuria, low risk of ASKD progression, but exact effect of different protein type is not still known. Carbohydrates, we have not still known exact amount of carbohydrate, apart from the fact that, as madam told in that plate, we have divided into vegetable, starch and meat and protein. Intake of whole grain carbohydrate, more of fiber, and the 20 to 40 gram has been known to slow the progression of chronic kidney disease. Prescribed diet, two most famous diet prescribed are the dietary approach to stop hypertension and the Mediterranean diets. We'll discuss that in detail later. Sir, please, next slide. So non-dialysis, we know that non-dialysis dependent chronic kidney disease, the national NUNS data, which is the National Nutritional Examination Survey, demonstrated average dietary protein intake in US was 1.3 or of ideal body weight or 1.09 of actual body weight. So incrementally high dietary protein intake is also observed in younger versus older patients. Next slide. Although the current guidelines for diabetic patients without kidney disease have actually not been recommended, among patients with diabetic kidney disease, the potential and benefits risk of a low protein diet has been widely debated. So what is the source of dietary protein intake? In an RCT with a 4-year follow-up, soya protein was used in place of animal protein. This is the use of 35% animal with 35% soy origin and 30% vegetable protein as against 70% animal protein and 30% vegetable protein. In this group, there is a significant decline in the amount of proteinuria at the end of 4 years in the group which is on soya origin protein. And also we have a study from Singapore which showed that there was an incrementally high red meat intake was strongly associated with increased high risk of SRD. But still, we know the famous on-target trial, which is the ongoing telmisartan and telmisartan versus ramipril trial. A secondary analysis of that trial showed that a higher animal protein intake, along with moderate alcohol consumption, was associated with a lower risk of CKD. So, so different studies have come out with different outcomes. In this NANS third cohort, we have seen that the GFR less than 60 and GFR more than 60, there is those who consume more plant-based protein had reduced death rate in the GFR less than 60, but this beneficial effect was not observed in patients with GFR more than 60. Next slide. Next slide. Next. Next slide. So you have seen that numerous observational studies have found a correlation between low dietary protein intake and high risk of death and hospitalization in hemodialysis patient. In hemodialysis patient, the same level of protein that we recommend for a patient not on dialysis cannot be used. So in comparison, non-dialysis, the guideline suggests a higher dietary protein consumption of more than 1.2 gram per kg body weight per day. Next slide. So the NKF-KEDOKI recommendation apply to the entire CKD population, including both dialysis-dependent and non-dependent individual in case of energy and carbohydrate intake. That is should be around 30 to 35 kilocalorie per kg body weight, and it has to be individualized to daily adjust the calorie intake. Next slide. For an elderly, here we have to be a little bit cautious. For elderly who are inactive, like most of our patients are, a daily calorie intake of 30 kilocalorie per kg body weight might be sufficient. In an obese person, that should be cut by around another 50 to 750 calories. So around 1200 to 1500 calories for women who are obese and around 1500 to 1800 calories for men. Because obesity, as we all know, is a risk factor for diabetic chronic kidney disease and CKD kidney disease itself, and also glomerulopathy like ORG and all. So consuming low potassium fruits and vegetable in a case of advanced chronic disease, phosphorus binder when it has to be used. We have to avoid processed high convenience milk with high phosphorus content. We know that animal origin, the phosphorus is in the shelf products, but the phosphorus from the plant is in the phytate state that is not observable. And the use of cooking methods that lower the potassium and phosphorus level, earlier washing, soaking the food in water overnight, or microwaving the food, these are all been known to reduce the potassium and phosphorus content of the body of the food. Next slide, please. Next slide. About fat intake, we know that dyslipidemia is a critical aspect of management of diabetic kidney disease, but the optimal amount of dietary fat has not been identified. There is a widespread agreement and recommendation that individuals with diabetes have a lower risk of cardiovascular disease when their consumption of saturated fatty acid and trans fat is reduced. Next slide. So it is advisable to keep the saturated fat at less than 7% of daily calories or less. The evidence that the kind of fat consumed has greater impact on metabolic status than total fat intake. And we have already discussed the omega-3 and the 6 polyunsaturated fatty acids have beneficial on the diabetic kidney disease outcome. in relation to proteinuria and progression of chronic kidney disease by attenuation of inflammation and endothelial dysfunction. So, in some studies regarding the fat intake in diabetic kidney disease, of a multicentric study of 192 patients with type 1 and type 2 diabetes and albuminuria, those who experienced a rise in albuminuria had higher saturated to polyunsaturated fatty acid ratio. However, the PUFA consumption did not impact the incidence of new onset albuminuria. This case control also observed a marginal significant inverse trend for high dietary PUFA intake and low incidence of KSRD. The origin study, which used the glargine, which included 12,000 people with impaired IGT and impaired fasting glucose, revealed a detrimental impact of omega-3 PUFA on cardiovascular disease and mortality. So, and sodium, we all know, as I have told earlier, sodium intake 1.5 to 2-3 gram per day is recommended for low diet of sodium has been linked to lower blood pressure, lower proteinuria. But also some studies that too little salt has a negative impact on glucose metabolism and lowers insulin sensitivity. So in addition, reduced dietary salt consumption may further diminish insulin sensitivity due to activation of the RAS system. So sodium limitation should be individualized. Next slides. Next slides. Next slide. Next. Sir, next. So I will now come to the prescribed, what are the prescribed diets for management of chronic kidney disease such as diabetes.
Rudrashis, kindly sir, complete in 2-3 minutes.
Okay, sir. I will, sir, complete, sir. So just next, please go to the next slide, sir. I will just compare the two diet which are prescribed diet, that is the DASH and the Mediterranean diets. Next slide. The DASH, we all know that it has a higher intake of potassium and phosphorus through dietary approach to stop hypertension in the level of 4.7 gram for potassium and more than 2 gram of phosphorus. But this dietary approach to stop hypertension may be beneficial for diabetic patients without kidney disease. But certainly, such a high level of potassium may not be is questionable in patients of kidney disease, diabetic kidney disease. So it is not a universal. And the Mediterranean diet, we know this Mediterranean diet has the RCTs have compared the DASH and the Mediterranean diet. They have found a high amount of unsaturated fatty acid in the Mediterranean diet, and well as consumption of red wine. And this diet has been associated with low risk of metabolic syndrome. And this diet, adherence to this diet was associated with low risk of decline in eGFR. Next slide. Next, third, sir, go to fourth slide, sir. Last slide. I will wrap up, sir. Next. Next slides. Next slides. Is this one, previous one. This previous ones. So what are the future areas of research? We know that there are multiple areas of uncertainty in respect to nutritional management of diabetic kidney disease, because there is no specific approach. The patient's approach will change from stage 1 to stage 2, non-dialysis to dialysis, transplantation. So the optimal amount of dietary protein among non-dialysis patients with diabetes, as well as the comparative effect of animal versus plant-based protein sources, is all requires further study. What are the cardiovascular outcomes to preferred types and amount of dietary fat in diabetic kidney disease diet? It still needs complex introspection and outcome. The role of the healthy diets such as DASH and Mediterranean diets also needs to be further studied. Next slide, sir. So we know that given the extremely high mortality and morbidity in diabetic kidney disease patient, vital significance of the nutritional status of the patient is large. And that is a largely unused approach in our armory that we seldom use in treatment of diabetic kidney disease or chronic kidney disease for that matter. And this remains to be seen in future if we can come up with specific and pinpoint nutritional guidelines. So summarizing, we know that the protein intake should be kept at 0.8 gram per kg body weight. And I have not told about VLPD, very low protein diet, that is still less, around 0.4 gram per kg body weight. And the long-term restriction of dietary protein in case of DKD is beneficial in maintaining the GFR and the protein intake should be around 16 to 18%. And those who are reliant on dialysis will go for a higher amount of protein to the level of 1.2 gram per kg body weight. I thank Dr. Kanungo for allowing me to present this topic, and this slide may all of me have not have followed because of the this problem from my side. I apologize. Thank you, sir.